Okay, let's set a scene. Imagine this. You've had a fall, your wrist is just throbbing, and you head straight to an urgent care clinic.
The classic scenario. It's quick, it's supposed to be convenient,
Exactly. So they take an x-ray, and the clinician, a nurse practitioner, maybe a PA, comes back into the room.
and they tell you, based on what I'm seeing here and your symptoms, we suspect a fracture.
Right. So they immobilize you, they fit you with a sturdy splint or maybe a boot. That's what we call durable medical equipment, or DME.
And they send you off with a referral to see an orthopedist. The system works.
But here's the twist, and this is really the core of our deep dive today. A few days later, you get a notification.
The follow-up.
The final official radiologist's report, the one that's signed off by the expert who's reading the films later.
In a quiet office with better screens.
And he gets back with a totally different conclusion. It says, no fracture, severe soft tissue sprain.
And right there, the whole system just kind of freezes. The patient starts thinking, wait, is my insurance still going to pay for this expensive boot I'm wearing?
And the clinic is worrying about chargebacks. The clinician is left wondering, what's my liability here? I prescribed something based on a preliminary read that was overruled.
It's that classic conflict between speed and perfection.
So our mission today is to untangle this. Whose diagnosis actually determines the insurance coverage? Is it the clinician's call in the moment, or is it the radiologist's final official read?
And crucially, what are the real legal and administrative risks for that clinician who's caught in the middle? We've dug into sources on urgent care billing, clinical liability, all the workflows around these disagreements.
What did you find?
Well, the answer really gets to a fundamental truth about how urgent care actually works financially in the US. It's a bit counterintuitive, but here it is. Insurance coverage for the treatment and that DME. It's almost always based on the treating clinician's diagnosis at the time of service.
Wait, really? That seems backwards. We rely on radiologists for their specialized expertise. Why would the system prioritize the initial read over the final signed expert report?
It all boils down to two things: timing and necessity. Urgent care centers, they have to bill quickly.
To keep the lights on.
Keep the lights on. To start that process, they immediately submit a claim. And that claim needs to include codes for why you were seen and codes for what was done to you.
Okay, let's break down those codes. I think they're the engine of this whole thing, right?
Absolutely. So the clinician uses what are called ICD-10 codes. That's the why. In this case, it might be, suspected fracture of the distal radius.
A specific code for a suspected injury.
Exactly. Then they use CPT or HCPCS codes for the what. That's the X-ray, the office visit, and the application of that splint or boot, the DME.
So the insurance company only sees those codes at first. They don't have the full story.
That's the key. They see the clinician's documentation supporting the medical necessity of the treatment at that moment. The final radiologist report, the one that might contradict that suspicion.
Yeah.
That often doesn't even arrive for 48, maybe 72 hours after the claim has already been sent out. Insurers they don't wait for the final read to process and approve the DME.
So let me get this straight. Even if the final report comes back and changes the diagnosis from suspected fracture to severe sprain, the insurance company is probably still going to cover the boot.
Yes, because the decision to immobilize was medically necessary based on a reasonable suspicion when the patient was actually there in pain.
So they're evaluating it in good faith at the time of service, not with perfect hindsight.
Precisely. If you come in with all the classic symptoms of swelling, acute pain, you can't bear weight, and that first X-ray is even a little bit ambiguous, treating it as a fracture is the standard of care.
And that decision supports the billing.
The coverage stands.
Okay, but this has to bring up the big fear everyone has: the retroactive denial. The idea that the insurance company is going to see that disagreement and just claw back the payment.
That is such a pervasive myth, especially among clinic managers.
Yeah.
While it's technically possible, insurance companies do not routinely deny coverage just because a diagnosis was refined 2 days later.
As long as the initial call was reasonable?
As long as it was clinically reasonable, yes. The initial assessment carries a huge amount of weight because urgent care is, by its nature, a time-sensitive, presumptive environment.
But you still have two different interpretations of the same X-ray floating around. What happens then? Which one is the official medical record?
Great question. The document that creates the official legal medical record is the one that's electronically signed and finalized by the attending radiologist. That is the definitive read of the imaging.
No.
But, and this is the key tension, even with that official signed report, The treating clinician still holds the final authority to decide on the patient's diagnosis and treatment plan.
So even if the signed report says no fracture, the clinician, knowing how the injury happened and how much pain the patient is in, can still say, we need to immobilize this.
Exactly. They can just code it as a severe sprain requiring immobilization, for example, and the treatment is still completely valid for billing. Clinical judgment can, in effect, override the imaging when it comes to the decision to treat.
So if a denial does happen, what's the real reason? If it's not this medical disagreement,
It's almost always just administrative hiccups.
like a typo.
Basically, the claim gets rejected because, say, the documentation of the symptoms was poor, so the ICD-10 kind of wasn't justified. Or, and this is more common, they just use the wrong CPT code for the splint.
Or the DME vendor bills it incorrectly.
Right. These are all administrative errors. They create a temporary denial, but they are almost always fixable with an appeal because that underlying medical necessity from the visit, it usually holds up.
This clarifies so much about the billing side, but it leads us right into what our sources call the managerial paradox. If the insurance coverage is usually solid and the clinician's judgment protects the bill, why are urgent care managers, especially in the big corporate chains, so anxious about this? Why do they make policies that say, wait for the final radiology report before you give out that expensive boot?
This is a perfect example of how corporate pressure and just a fear of paperwork can completely supersede clinical reality. That delay you're talking about, it's driven almost entirely by administrative anxiety.
Not by actual insurance policy.
Not at all.
So walk us through that fear. What are they actually afraid of?
Okay. They're terrified of two main things. First, the medical necessity audit. Even if the insurer pays the initial claim without a fuss, big corporate chains are under more scrutiny. They're afraid an auditor, maybe months later, will question every service tied to a suspected fracture that turned out to be a sprain.
Including the x-ray itself.
Yes. They see that final signed report as a weapon an auditor could use against them.
Even though the standard of care would support taking an x-ray based on a reasonable suspicion.
Correct. But for them, minimizing administrative hassle is often more important than clinical efficiency. And the second thing is just avoiding write-offs. Every denial, even if you can fix it, costs staff time and money.
So the big chains just issue these rigid rules.
Exactly. Don't put anything over $500 on a patient until we have confirmation. It's purely to reduce the number of little disputes that might end up as a loss on the corporate spreadsheet.
It really sounds like the management and a lot of the Martin clinicians are just reading the risk all wrong.
That's the core insight right there. They're confusing the high chance of a minor administrative denial, which is fixable, with the very low risk of a major retroactive denial based on sound medical judgment.
So their caution is based on fear, not fact.
It's based on internal metrics and corporate policy, not on the nuances of clinical documentation or actual insurance rules. And these policies, which are meant to prevent write-offs, they end up delaying necessary care for the patient.
That distinction is so important for understanding why your visit sometimes feels overly cautious. Okay, let's pivot now to the legal side. We've covered the money. What about professional risk?
Malpractice.
Yeah. If the clinician misses a subtle finding, let's say they fail to prescribe a sling, and the radiologist later finds a significant issue, is that clinician exposed?
This brings us right to the concept of the standard of care. It's the legal benchmark, and liability isn't based on whether your diagnosis was perfect.
It's based on what a reasonably careful clinician would have done.
In that exact same situation, with the same information and time pressure, perfect accuracy is not the standard.
Okay, let's use a clear example. A patient comes in, looks like a classic ankle sprain, some swelling, they can put a little weight on it. The clinician looks at the x-ray, sees nothing, and diagnoses a moderate sprain. Sends them home with a compression wrap.
That's a totally acceptable clinical decision. Now, even if the radiologist later uses, special tools and finds a tiny hairline fracture that was basically invisible, the initial treatment is still highly defensible.
Because to prove malpractice, you need three things.
You need all three. Negligence, meaning the care fell below the standard. Causation, meaning that negligence directly caused harm. And damages, an actual injury.
And in that scenario, there's no negligence.
Exactly. The clinician acted reasonably, and a few days' delay in diagnosing a hairline fracture that wasn't even visible, that rarely causes any significant permanent damage. So you don't have a case.
But what if the finding is more significant? Let's take that shoulder injury you mentioned. The clinician misses a moderate AC joint separation, but the radiologist's report, 48 hours later, catches it. What happens then?
This is where the workflow is actually designed to protect the clinician. Missing something subtle or complex on an initial read is understood to be part of the process, especially in urgent care.
The standard of care doesn't demand that every clinician also be an expert radiologist.
No, it doesn't. But what the standard of care does require is timely follow up.
Once that new definitive information is available,
Yes. The clinician has a duty to review that final signed report. And if it shows something significant that changes the plan, they have to act on it promptly.
what does acting on it look like?
It means you pick up the phone, you call the patient back, you update the diagnosis, you adjust the treatment, get them that sling they needed, and you make an immediate documented referral to orthopedics.
And that documented timely correction is considered good enough.
Our sources are clear on this. It's considered appropriate and sufficient care. It closes the loop. It protects the clinician from liability because they fixed the problem as soon as they definitively knew about it.
It really just highlights that in this kind of fast-paced setting, the responsibility isn't so much about initial perfection, but more about system diligence.
It's about making sure that follow-up happens. The system accounts for the time pressure. If the clinician is diligent, reviews the reports, and acts, they are meeting the standard of care.
So as we wrap up this deep dive, the key takeaway for you, the listener, seems to be this. When you're in that urgent care setting, the whole system is built to prioritize the initial clinical decision.
Right. The critical determinant, both financially and legally, is the initial clinical judgment and the documentation of necessity that happens right there at the time of service.
Not the report that clarifies things 2 days later.
Exactly. And that difference between the official signed radiology report and what you could call the operative clinician diagnosis, it reveals that core tension in urgent care. It's a race against the clock.
And the person who acts first, the clinician, is the one who carries that primary responsibility for both the treatment and the bill.
Which is why documenting why they suspected the injury is so much more protective than waiting around for perfect certainty.
It's a really interesting structural reality, isn't it? So here's something to think about. While that final signed radiology report is the permanent official document for the medical record, the immediate decision to treat you is what actually determines your care and your bill. And that decision is based on human judgment before all the evidence is in.
Mm.
So think about other areas of medicine that are under similar pressure, like the ER. In what other situations should that human imperative to act fast, to treat the person in front of you, legally and financially, trump the need for perfect final scientific certainty?